hello there. It's your girl Valerie Mason Chase again, and welcome to another episode of Marriage Beyond the Breach. I thank you for watching, whether you're watching live or whether you're watching later. Um, Anytime you tune in, I appreciate you. And if you have not already done so, I would very much appreciate if you would go to our YouTube channel, Marriage Beyond the Breach, subscribe, like, share, do all of that good stuff. And we like to have our conversation be as interactive as possible. So feel free to comment, ask questions, do all of that good stuff. So we have what we're going to talk about tonight. We're going to talk about women's health. Okay. And I think it's important for us to talk about women's health. We are women and we need to know as much as we possibly can about our health. Hey, Nicole, thanks for tuning in. And anyone who's watching right now, just give a shout out. Hey, Elder, how you doing, Elder Gail? Women, we as women need to know. And I think the brothers need to know too. Because I think sometimes it is alarming how little some men know about women's health and about the female body. Some men wouldn't know a clitoris if it came up and smacked them upside the head. They wouldn't know what it is. Okay? So if a sister is on here and you have a brother in your life, you got a man in your life, you know a man, reach out to him, share this with them, because we're going to be talking about a lot of stuff regarding women's health on tonight. And again, feel free if you have any questions, any comments, we welcome them. So I have a very, very special guest with me tonight. I met this young woman many years ago because she happens to be the very bestest friend of my cousin Elaine in Brooklyn. And I've always been impressed by this woman. So I am going to bring her on, none other than Dr. Paige Long Sharps. Hey, Dr. Paige.
Hi. Hi,
I want to
everyone.
thank you. I want to thank you for taking the time out to be with us here on this evening. So I think you are phenomenal. I think you are so special. So those who don't know you, just share a little about yourself.
Okay, so as you said already, my name is Paige Long Sharps. I am a obstetrician gynecologist by trade for, I guess, over 25 years now.
Mm-hmm.
I practiced for about 20 years at Montefiore Medical Center in the Bronx, um, taking care of Black and Brown people. Did that as the medical director of the clinic that I was assigned to until I had to leave for some medical issues. I then started teaching at PACE for their physician assistant program. Love that. And then transition into insurance, which is what I'm doing now with working for United Healthcare. But definitely trying to get back into the clinical field, currently transitioning to telehealth and want to be fully engaged in women's health and interacting with that. I'm also married. I have 2 kids in college. My oldest son is at my alma mater at Howard University, HU, and my younger son is also at a HBC, Morgan University. And so I'm just happy to be here, happy to empower women and, have a good time this evening.
Absolutely. And you talk about HBCU. I'm repping my HBCU tonight, North
I see.
Carolina A&T State University in Greensboro, North Carolina. Go Aggies.
Yes, I have 2 cousins there.
Sadell graduated from Howard. I don't know if you knew that. My daughter
Yes, I
Sadell.
do. Yes,
Yeah.
I do.
All right. All right. Repping some HBCUs tonight. I love it. I love it. I love it. So as we get started tonight, I want to ask, hey, Toya, thank you for tuning in. Can you start by explaining what you believe are the most common health challenges that women are facing today?
It's a good question, and we can talk about diseases of particularly GYN. We could talk about heart disease.
Mm.
We had a Black Family Wellness Day yesterday for one of the organizations I belong to, the Links Incorporated.
Mm-hmm.
And one of the members, she got up and she stated that when we're on the airplane, and you know how they tell us to put your oxygen on first before you can help your kids or help anyone else.
Mm-hmm.
That's what we need to do as women. And I think that's
Mm.
first our biggest challenge in taking care of our health. We need to
Wow.
become more selfish. And I know we
Yeah.
are taught to not be selfish and to help others,
Yeah.
but we are mothers, we are wives, we have careers, we're working, we're involved in our church, we're involved in community organizations. Something
Yes.
is going to give. And usually
Mm.
it's our health. And so
Yeah.
that number one is our biggest challenge, taking care of self. And when we
Wow.
realize we have to take care of self, then everything else will fall into place. We'll take care of our annual visits, our cancer screenings, all of those things. But I think really that's our biggest challenge as women right now.
Wow, that's good. And let me just say this real quick. This is actually part one because I have so many questions for Dr. Paige. I already know we're not going to get to cover them all tonight. So I'm calling this Women's Health Part One. And
Okay.
it's so interesting that you said that
Mhm.
because, I transitioned from nursing to counseling
Okay.
back in 2020. And I can tell you without fail, most, if not all, of the women that I counsel, whether as individuals or as part of a couple, self care is missing from their life.
Yep.
And it's something that we have to spend several sessions talking about, even to get the woman to a place where she's comfortable even considering engaging in self care. So that's interesting that you said that because I think we don't do that a lot. We don't do it enough.
Right. Because again, we're taught to take care of others, to
Yeah.
be, not selfish. And we got to turn that around for our health
Yeah.
because we're dying. We are dying.
We are dying. That's right. There was a time when heart health was more of a male concern than a female concern, but that's no longer the case.
Correct. Correct. It's
Wow.
definitely number one killer for women right now. And when we even think of heart disease, we think of the old man clutching his chest, and that's no longer the case. It's women, and particularly women of color.
Yeah.
Because again, we ignore the signs. Oh, it's a little heartburn, or I'm just stressed. Oh, I don't feel too well. All these things that we ignore. And by the time we get to the doctor, prayerfully before we have a stroke or something, a lot of times now we're trying to catch up and do all of this preventative care that we could have taken care of had we listened to our bodies.
Yes, yes. I think we underestimate within our community the importance of that healthcare on the front end, so you're not treating disease on the back end.
Correct.
That preventive care.
Correct.
Yeah, we don't talk. I don't think we talk enough about that.
Yep.
So, Dr. Paige.
Yes.
From your perspective, what are some misconceptions about women's health, especially as it applies to our reproductive system?
Before we talk about misconceptions, I think we need to address that women right now, we're just 0.4% more of the population than men. So we're about even. But we're 50.4% of the population is women. Okay. Right. And I think they predict by 2040 that we're going to overpopulate men. So with that said, women's health, there is no funding, there's no research. All of that has traditionally been lacking. So last year, Biden, behind his wife, Jill Biden, Dr. Jill Biden, they
Mm-hmm.
put into a new initiative to fund women's health. And so they're pouring
Mm-hmm.
millions of dollars. I think it's something like $83 million that they're
Mm-hmm.
going to be pouring into research now for women's health. Because a lot of these studies are not necessarily studied on women, definitely not
Right,
people
right.
of color. So there's this new initiative now, and hopefully, well, we won't even talk politics, but if that other person doesn't get in office, hopefully he won't dismantle
Yes.
it. But we need so much money and funding and research for
Mm.
women's health. So thank God that is now they're realizing that all the big buzzwords now are disparities and maternal health and all of that now. So now, all of the attention is turned to that. But I
Yeah.
think if we talk about women of color, particularly
Mm-hmm.
misconceptions, we don't have problems getting pregnant.
Mm-hmm.
We can tolerate pain.
Mm.
After surgery, they're just complaining. They don't necessarily need as much pain medication.
Mm-hmm.
So I would
Mm-hmm.
say those are, the big misconceptions, particularly, and that we just don't go to the doctor. Or we, treat the emergency room as our primary care,
Very.
and that may
Mm-hmm.
be true in some cases, but that's not really the truth.
Right.
I think women get frustrated, particularly women get frustrated because let's face it, a doctor is going to respond a different way to a male,
Mm-hmm.
white male, then he's going to respond maybe a little bit better to male of color. And then
Mm-hmm.
to women, they're going to respond totally different. So
Yes.
when you go and you talk about your problems,
Mm-hmm.
um, oh, don't worry about it. They minimize our symptoms.
Mm-hmm.
So a lot of misconceptions is that we don't know what we're talking about. We don't
Mm-hmm.
know our bodies. They know more. So we have to really start advocating for ourselves. You know,
Yes. Yes.
bring somebody if you feel you're a shy person and can't
Mm-hmm.
really get across. Even if you can't bring someone, call on the phone, be on
Mm-hmm.
FaceTime
Mm-hmm.
when you're at the doctor's office so that the other person can hear and help you navigate through that visit.
Yes. That is so good. There was a couple of things you said, and I want to kind of piggyback on a couple of them.
Mm-hmm.
One thing you said about the funding of $83 million,
Mm-hmm.
and 83 million sounds like a lot,
And
but
it's
when
not
it comes to research, 83 million is really not a lot.
exactly,
But the fact
exactly.
that they're allocating any funding is a good thing. So
Mm-hmm.
hopefully this will be a start.
Mm-hmm.
And a year from now, 5 years from now, 10 years from now, that number will double or triple or quadruple.
Correct.
Yeah, that's good. And it is so true what you said about doctors poo-pooing women sometimes when we come in. I started as a nurse back in 1978, and things
Mm-hmm.
were very different then as than they are now, as you can imagine.
Right.
But there were times when women would come in and they'd have symptoms, and sometimes they weren't very clear. They might have kind of vague symptoms, and based on what the woman would say, the physician would order certain diagnostic tests.
Right.
But when those tests might come back and not show what the physician was anticipating,
Mm-hmm.
now they want to do a psych consult. That was the big thing back then. If they can't find a reason for the symptoms you're having,
Right.
then these got to be somatic symptoms,
Mm-hmm.
and you have got to, go and have the psych consult. I didn't see that as much towards the end of my career as I did in the beginning, but I
Right.
wish I could say it wasn't present at all.
Right.
And
Right.
one of my nurse sisters is on here. A couple of my nurse sisters is on here. Candy, who I went to A&T with, we graduated
Mm-hmm.
together, and Nicole. So
Mm-hmm.
you guys can share what your experience has been regarding that in terms of the difference in the way that women in general and women of color in particular are received, as opposed to men. So yeah, That's very, very true. But like I said, it's
Mhm.
changing, but it's not changing fast enough.
Right, right. And it's
Changing
not
fast
changing as fast enough again for people of color.
for people of color. Yeah,
They're
that,
crazy. They don't know what they're talking about.
right.
That
And
can't be.
here's the big thing: coming to ER with pain, they think it's when a black person they put on the chart drug seeking. That used to piss me off when I worked in the ER, and you'd have someone come in with legitimate pain. Listen,
Right,
you're drug seeking. They're seeking a drug. No, let's find out what's the source of this.
right.
Now,
Well,
were there
well,
some who would come in drug seeking? Yeah, but that
yeah.
doesn't mean every black person that comes in your emergency room is seeking drugs. Yeah, go ahead, Dr. Page. What were you going to
No,
say?
sorry to try to cut you off. But
Mm-hmm.
when just mention that, it makes me think all the time, especially on the labor floor, when women are coming in pain. And one of the hospitals that I worked at in the Bronx, we catered to, of course, the Bronx community.
Yeah.
But because of the specialists there, we got a high population of particularly Jewish women a lot as well.
Mm,
Oh, a little pain. Oh, let's get them something for pain. Or let's
right.
give them some rest where we might just give them a little cocktail so that they can sleep and let them rest. And then maybe they'll go home if they're not in active labor.
Mm-hmm.
Women of color, first, they just here for something for pain. And so again, about misconceptions, our pain isn't real.
Right.
It's ridiculous. Or a sickle cell, have
Mm,
someone who is pregnant with sickle cell and pain, and they're seeking drugs. Sickle cell pain is very, very real.
yes.
And so to ignore that is crazy. To
Yeah.
first thing out your mouth, oh, they're seeking. But I have seen that change. I really have, especially in sickle cell sensitivity about that more. I'm
Yeah.
not saying it's completely gone, but I have
Right.
seen from when I was in medical school to now
Right.
how
So
it
now,
definitely have changed.
absolutely. Because
Yeah.
my sister friend Angel, another nurse, she said she has a niece with sickle cell anemia, and that's the
Mhm.
first thing they think when she's having
Right.
a crisis, just as you
Right.
mentioned.
Right.
Absolutely. Wow. And Nicole, another nurse, sister friend, she says it's prevalent for people of color. It's still
Hmm.
an uphill battle every day.
Yeah.
Wow. You wouldn't think that we'd still be talking about something like that here in 2024, right?
A lot of what we're talking about in 2024 is like, are you living in the twilight zone?
Yeah,
It's unreal.
that is so true. Okay, so this is going to be for all of us, but especially for the brothers. Can you provide an overview of the key components of the women's reproductive system and their functions?
Wow. Yes, that's real, real simple. Like you said, some men don't know. We won't even talk about some women. Before I go into that, I always think about uh, when women would come in complaining of itching, particularly itching, if they had something
Mm-hmm,
as simple as a yeast infection.
mm-hmm, mm-hmm.
And I would say, is your partner circumcised? What's that?
Mm.
And another time, a lot of times they would say they don't know because they're just not looking.
Oh no, you need to look. Matter of fact, you need to get one of these hair things and look.
Turn on lights, get my
Yeah.
everything, magnify, whatever. So some of us are a little ignorant as well. I won't say men are ignorant, but that just used to infuriate me. I'm like, come on, sex is very, very intimate. How do you have something in your body parts you don't even know what it looks
You
like?
don't even.
Have
Wow.
big boombas on there and you're clueless. But anyway, women's body parts. We as men all know what a vagina is.
Mm-hmm,
So we know
mm-hmm.
that's the conduit for sexual intercourse. But as you go into the vagina, you're greeted by the cervix, which is the mouth of the womb,
Mm-hmm,
which is
mm-hmm.
the medical term is uterus for that. think of a uterus, say maybe as a balloon. Then you have two Mickey Mouse ears if you want to attach that, which are your tubes coming from your uterus. At the end of your tubes, think of two little golf balls. And you know how golf balls have those little craters in them? So think of that as all of your follicles, which are your ovaries, which are follicles. Unfortunately for women, we are born with all the follicles we're ever going to have in life. So as we keep getting our menses and we're not getting pregnant, we're just losing all those follicles.
We're losing them.
Men make semen every day. And if they make a full new stream, it's every 64 days. So hence why they can have babies till they're 80, 90 years old. And we can't, because once we hit menopause, we'll get into that. Your eggs are.
I gotta have a conversation with God about that when I get to heaven.
You know? But I make a joke, and when men say they don't understand, I said, well, it's a pause from you. Men, pause. Men,
right?
Go away. Leave me alone. It's a pause from you.
It's a pause. Right. So I just want to ask about I'm sorry. Were you still?
No. So I mean, those are all the parts, and then obviously, I think our audience knows how you get pregnant. The semen up the cervix, out the tube, meet a follicle, and then it implants on the lining of your uterus, which is the same lining that sloughs off every month if you're not pregnant, and that's as menstruation. So, yeah.
I know I didn't have this as a question, but if you can just talk for a minute about hysterectomy and the difference between, because you can have just a hysterectomy, you can have a total hysterectomy with your tubes removed and your ovaries removed, and the different impact it'll have on a woman. Because some women think if they have just their uterus removed, they're going to go into menopause. Right. So just explain the difference in the types of hysterectomy.
Right. So you have total hysterectomy, which actually is taking your entire uterus and your cervix. You can have a hysterectomy where you leave part of your cervix, because there is myth that cervix helps with intercourse. So if you leave your cervix, they won't lose necessarily that sensation with intercourse. If you take your tubes and your ovaries, that's a total hysterectomy, bilateral salpingo ovarectomy, which is both tubes and both ovaries.
Yes.
When you take, and sometimes we take the tubes and we still leave the ovaries. So that's just, partial taking the tubes with the uterus. Yes. When you take your ovaries, that's surgical castration. You have now removed your source of all your most of your female hormones, particularly estrogen and progesterone, which is coming from your ovaries. So when you have that removed, now you're in menopause. You've been put into menopause via surgery versus naturally when your ovarian reserve just goes kaput.
Yeah. And because some women don't understand the difference. And I think it's incumbent upon whomever the surgeon is to explain what the differences are.
Exactly.
When I had my hysterectomy, I had my uterus removed, my cervix removed. I had my fallopian tube and ovary removed on one side, because the other side was okay. And I knew if I had at least one ovary there, I wouldn't go into menopause right away.
Correct.
Because I had the option of removing everything, but I didn't want to go into menopause just yet. So I had her leave one tube and one ovary. But I think the whomever the surgeon is really need to explain what your options are. Because if your ovaries are healthy and it's just your uterus, you can have just your uterus removed.
Correct. Traditionally, ovaries were removed, not automatically, but just thrown in there because you've now pretty much made your risk of ovarian cancer zero. And we know
Right.
ovarian cancer is one of the most deadly women reproductive cancers, because it's
Mm.
usually diagnosed at such a late stage
Makes
because the
sense.
symptoms are so vague that by the time you
Mhm.
catch it, it
Yeah.
could be
Yeah.
terminal. So we felt,
Mhm.
remove the ovaries, we don't have to worry about that. We have negated
Mhm.
the
Mhm.
risk of ovarian cancer. However, more women, rightfully so, started advocating, and look, I'm in menopause and this is crazy. So
Mhm.
can I
Mhm.
keep my ovaries? And that hence has, made a wave
Yeah.
of a lot
Yeah.
of women now keeping their ovaries so that they
Mm.
don't go into immediate menopause. But I, would still recommend, if you're say 48, 49, take them
Right.
out. I
Mhm.
personally, because
Right.
when you see such bad ovarian cancer, to me,
Mhm.
it's just not worth the risk.
It's not worth it. Yeah.
Yeah.
So now that the blood test for ovarian cancer, what is it? CA something something? I forget what it's
Well, you
called.
have the CA 125, you have
Yeah.
CEA 19.
Uh-huh.
Um, I'm thinking it's another tumor marker, but
Yeah.
those are, they're helpful. They're not screening tests, and a lot of oncologists will say they use those tests more so to see maintain a remission status versus
Mm.
diagnostic.
Oh, okay. Okay.
Yeah. So
Good. Good.
just because it may be low doesn't mean you don't have cancer,
Don't
and
have it.
vice versa, but once
Right.
you are diagnosed, then they can really use it in terms of to see if you're staying in remission versus maybe you're having a recurrence.
Got it. Got it. And those of you who are watching, please don't hesitate. If you have questions, put it in the chat. Put it in the chat. So, Dr. Page,
Yes.
do lifestyle choices impacts women's reproductive health? And what recommendations do you have for promoting
Mhm,
reproductive wellness?
mhm. Again, we come back to that oxygen mask. So
Mm-hmm.
taking care of self and
Mm-hmm.
mental health, reducing
Mm-hmm.
our stress, uh diet and exercise, definitely. I mean, diet has just taken the gamut from eat more fruits and vegetables, eat less red meat, um
Mm-hmm.
don't eat, before it was don't eat pork, now pork is the new white meat.
White meat.
You can't keep up with all these things. Now everything's organic. Now we have
Mm-hmm.
different degrees of vegetarianism. You are total vegan. Maybe you only eat fish, so you're a
Mm-hmm.
pescatarian.
Mm-hmm.
It's all these
Mm-hmm.
combinations, but we know from all studies that diet definitely impacts your health. It impacts your blood pressure. It impacts your risk of diabetes. It
Yeah.
impacts colon cancer. So it
Yeah.
has an impact on everything. But again, that tied in with mental wellness and stresses, so that you're not driving up your cortisol to be
Mm-hmm.
all stressed.
Right.
Um,
Mm-hmm.
that all ties in. And of course, exercise. And exercise can be sitting in your chair. If I have a desk job now, but get something where you're moving, your feet. They have those pedal things for you
Mm-hmm.
to put at the bottom of your desk. Now they have,
Right.
I actually just got a stand up desk so that I can stand um, a lot of half of the day versus just sitting down. So,
Mm-hmm.
exercise is key. Walk around the block, walk, some type of walking. It doesn't have to be a full membership at a gym, but just keep that circulation going. So that all,
Yeah.
ties in. And then, your vitamins, there are different vitamins that they feel may help women's health, vitamin D, definitely. I mean, we
Mm-hmm.
of color are
Mm-hmm.
suffering in that anyway.
Right.
But vitamin D and calcium, because we know that also ties into osteoporosis. So you
Mm-hmm.
want to, eat your definitely dark green leafy vegetables to help, that for your bone health. Um, what else? I talked about vitamin D. B12. My neurologist actually just recommended you need to be on B12, for your memory. So
Mm-hmm.
that, is a big thing now. Are we all forgetting because we're so overworked and we're
Mhm.
multitasking. And so,
Mhm. Mhm.
it's like you meet somebody that you know their name and you're just like, oh gosh, I don't even remember their name because our brain is just on overload.
Yeah. Yeah. Um, I think, yeah, that's interesting. And the thing about it is
Hmm.
vitamin D, your B families, B12, B6, all of those different Bs, and you can get that over the counter. You don't need a
Yeah.
script for that. That's an easy
No.
fix. Vitamin D, you can just go out. Well, let me put it like this: you can go out and get some sun,
Hmm.
but the others we could get it over the counter.
Right. Right.
Yeah, yeah.
I
That,
saw a commercial the other day, which I guess I knew this, but even for asthmatics, usually I have asthma. I was diagnosed with asthma at age 40, crazy. But
mm,
the inhalers that are prescription, even those are over the counter now.
oh,
They have different ones that you can just get over the counter. You don't even need a prescription. If you go
yeah,
online and you go to Canada, you can get anything.
that's true. That's what some of the men were doing to get their little blue pill.
Yes. And then coming in with priapism.
But for those who may not know, tell them what that is.
Oh God, that's an erection that will not go down. Yeah, so
It
be
won't go
careful
down.
of
And
those
guess,
little
and guess what
pills.
they have to do to treat it? Tell them, Dr. Page.
They don't want to
You
know.
know,
It's
it ain't
it's
pretty.
it's not pretty. It is not
It's not.
pretty. So be careful, ladies whose husbands are taking those pills. It's not like you take 5 and say, "Oh, I'm gonna have an erection for 5 hours." Not a good thing.
No, not a good thing. Absolutely not a good thing. So we spoke earlier about menopause. So just explain exactly what menopause is and the typical
Mhm.
age range when it occurs.
So, technical definition of menopause is no menstruation for 1 year, 365 days. You can go 200 days. If you
Uh
bleed,
huh.
you got to start again.
Mm
If you
hmm.
go, well, if you go 364, that just sucks. But I would say, so. But an entire year of no spotting, no period, nothing,
Mm,
bone dry. Once you've completed a year, you're now considered postmenopausal.
yeah, yeah. Okay. Okay.
Mhm.
And so what's the typical age range when it occurs? Usually.
51 is your average age. They say from like 48 to 52 is the average age. Do women get it early 40s? Absolutely. I've had patients in their 60s still bleeding,
Hmm.
and it wasn't any abnormal bleeding or anything like that. They just,
Right.
good for
Right.
them. They didn't have all the other problems that, I shouldn't say problems, all the symptoms and some of the uncomfortabilities that goes with menopause.
Yeah. And you mentioned women in their 60s and still having their menses and it's not abnormal bleeding. Talk for a minute about the significance of postmenopausal bleeding and why, if that occurs, a woman needs to check that out, get it checked out.
They need to run, run, run. And I think traditionally, I have a very good friend, her mom passed from uterine cancer. And I think
Mm-hmm.
her mom didn't tell her when she was spotting early on, because I
Mm,
think, like probably for my grandmother, maybe even my mother, oh, you have a little bleeding, it's no big deal. It's not a full blown period. You definitely don't have pain with it most of the time. So they
right.
don't think anything of it. But if you have gone an entire year without bleeding and any comes back, you run to the doctor. We can do something as simple as a sonogram, which will measure the lining of your
Mm-hmm.
uterus. And we use a certain number. And if it's over a certain number, then we might be more invasive to do an endometrial biopsy just to make
Mm-hmm.
sure you don't have risk of uterine cancer.
Right.
Now, there's been some studies that have come out of late that says for African American women, that
Mm-hmm.
same test we use to measure the lining of your uterus, we can't necessarily use it as textbook to say, oh, it's less than, say, 0.4 millimeters, you're okay. Sometimes we might still need to do an endometrial biopsy, which is actual tissue, and that's a more definitive diagnosis.
Mm. Okay. I hope you women who are listening are paying attention to that. Anyone who was postmenopausal, if you are postmenopausal and you experience bleeding, Dr. Paige isn't saying run, don't walk to your doctor.
Right.
Don't.
And it may be a lot of women who say, for whatever reason, they're postmenopausal and they haven't been sexually active, and then they get, a new partner or what have you, and they start having intercourse. The bleeding might be from vaginal or cervical and not anything to do with your uterus, but you still need to have it checked out just to see what it is.
Right. Okay. Okay. So we're still talking some about menopause. So what are the common symptoms of menopause? And how do they affect a woman's daily life potentially?
Oh my gosh. It can, some women are very blessed and they have very little symptoms. And God bless them. And then there are women who have anything from, we hear about the hot flashes. We hear about the mood swings. We hear about the vaginal dryness. We hear about decreased sex drive. It affects your bone, hair thinning, hair loss, itching of the skin. A lot of women complain about they're just itching all of a sudden. They haven't changed soaps. They haven't changed lotions. They haven't changed anything really. Detergents. They are just itching like crazy. That's one of the big symptoms of it as well, itching. We talked about hair loss, and bone. Sometimes vision. Women complain about their vision, that they're seeing kind of blurry at times. And we don't quite know what that is, but we are seeing that in menopausal women. Bloating. And then we all know about the weight gain headed south.
Yeah.
The abdominal increase, you kind of lose your waistline, and that, kind of congregates below your waistline. Yeah. So those are some of the more common symptoms that women complain about.
Wow. And that's a whole lot. You just said a whole lot.
It's really top to bottom of it affects your body. And postmenopausal women are at even more increased risk for cardiovascular disease. So that sucks too,
Yeah. So with congregate. She's talking about congregate, the fat that congregates around our midsection.
Okay.
Hormone replacement therapy is kind of controversial.
Mm-hmm.
So
very controversial.
Can you talk a little bit about that?
So you have the non-hormonal remedies, so to speak. You have homeopathic remedies, primrose oils, depending on what your symptoms are. Most of the time women are trying to get rid of those hot flashes. That's what they are.
I know. It's
really trying to so you have over-the-counter things. There is even now that a lot of these states marijuana is legal. You have different gummy bears with certain levels of cannabis in it that is targeted towards your hot flashes. Whether it works or not, I haven't seen enough patients say, oh, my hot flashes are gone. They do have, and I think I didn't mention insomnia. That is a huge symptom of menopause. So I know they have gummy bears with the THC targeted towards helping you sleep better. So we have, all of these hormones. You have the I'm having a brain freeze, but what is that? over the counter that everyone says to get. I tried it myself. It didn't do anything to help you sleep. I'm having a brain freeze right now. But ah audience, if someone knows, I can't think of it right now. But anyway, that's something common that people take to help go to sleep. Melatonin.
Melatonin.
Yes.
Oh, yeah. I use that.
Didn't work for me. But you know, a lot of people take some melatonin, you know, what have you. So you have all of the different non-hormonal treatments. And then you have the traditional hormone treatments. You know, you see people on the train in the street dripping in sweat, and you're like, oh my gosh, they need help. Like, there's no reason you should be walking around drenched in sweat like that. And so those women, they might need hormones, and that's a decision between them and their provider. You know, it's very personal. Definitely, if your family has history of breast cancer, you're going to stay away from that, because all of the studies have shown that hormone replacement therapy increases your risk of breast cancer.
Right.
So of course a woman is going to be leery of that. But you have all of the hormonal, which is estrogen particularly, and if you still have your uterus, you have to take some type of progesterone component, because you want to combat that buildup of your lining of your uterus. Otherwise, now you're causing uterine cancer with the estrogen. So you have to take a progesterone component with the estrogen. But you have pills, you have creams, you have shots, you have vaginal inserts, you have all different kinds of combinations of the hormone that you can take. What's new, a lot of women are doing the pellets. I don't know if you've heard of those, but it looks like a little, kind of like a big pill that is injected usually in your buttocks, and it can last a couple of months. And it is geared specifically towards the individual. So they run your hormones and your levels, and depending on what is bothering you. A lot of women, you know, I have two friends that, oh my gosh, they're like, it has changed their life. They sleep like a baby. Their sex drive is better. They are really doing fabulous with that. So that is, if you know, you want to do hormone replacement therapy. But we recommend, if you do any hormone replacement, it really, now we're saying a year is what we would, you know, love if you just did it a year. Traditional studies said no more than 3 to 5 years, but that's not something you're on 10 years. You know, a long time. And unfortunately, some women, they have menopausal symptoms for years.
Longer than that. I'm still having hot flashes.
No, when I say 4 years, not the number 4. 4.
Yeah.
40. Yeah. So it's unfortunate, so to speak.
Yes.
And now last summer, I don't know if you've seen a commercial for a new medication. Before I even jump to that, non-hormonal treatments, but still prescription. A lot of the antidepressants they felt work for hot flashes as well, and a lot of women did say they got a lot of relief with that. But some women are like, I'm not depressed. I don't want to be on an antidepressant. So, you know, psychologically, they don't like being on stuff that is labeled for other things. Clonidine is another medication that is helpful for hot flashes, and that's traditionally for actually blood pressure. So there are different medications that they're using off-label, so to speak, that will address hot flashes. But last summer, or maybe August, September, a new medication came out for hot flashes, Via Zua. Let me look up and see how you, because I had wrote it down because I knew I was gonna forget how to say it. It is Veozah, Veozah. And that is a new medication that has just come out, and it works in the brain. and it
Mm.
really tricks you into you don't have hot flashes.
Really?
And patients are saying it is a godsend because it's not
Wow.
estrogen or progesterone, it's not an antidepressant, it's not going to mess with your blood pressure. It is really revolutionizing taking care of hot flashes. If you have liver disease or end-stage kidney disease, you cannot take it. But
Mm.
otherwise, they're getting good results with that.
Wow. That's good to know.
Yeah. So
And
that's particularly for women also who have breast cancer and they can't take, the hormone replacement.
hormones.
This
Right.
works for them as well. So this
Yeah.
just came out last year, around August, September. So
Mm. Mm-hmm.
it's not a
Mm.
year yet that, we even have outside of the studies they did before it came out of
Right.
actual patients, within my circle to say, okay, how is it doing?
Yeah. That is so good. I think the underlining thing of all of what you just said,
Mm-hmm.
have conversations with your physician.
Yes.
And if your physician is someone that doesn't want to take time with explaining all of your different options, and you need a different doctor. I'm just going to say it. Okay? Because let's face it, the way some doctors' offices are scheduling patients, they only have 10 or 15 minutes with you,
Exactly.
that
Exactly.
long, and it takes time to explain all of what your options are. But
Right.
we also need to be kind of proactive and regarding our own health care. And if our physician says, okay, this and this and this and this are options, then maybe we can take it upon ourselves to go and
Right.
research those things
Exactly.
and determine what we think might work best in our particular situation, because it's not a one thing fits all when it comes to menopause.
Exactly. Exactly. Exactly.
So many different things. And I just want to say, women who suffer with vaginal dryness during menopause, you don't have to deal with vaginal dryness. There are options to address that. And
Right.
that I encourage, have conversation with your partner
Right.
when it comes to vaginal dryness, because if you don't say anything about it, then you end up having painful intercourse. And
Correct.
the more painful intercourse is, the more you're going to avoid it. And the
Right.
more you avoid it, the more it's going to impact your
Relationship.
relationship.
Yep.
Right,
Yes.
Dr. Page?
Absolutely. And there's so many things now for vaginal dryness, like you said. So no
Mm-hmm.
one should be suffering with that at all. Yeah.
Right.
And outside of,
100%.
don't put Vaseline, don't put baby oil.
Okay. I have two of my grandchildren here, so bear with me. She just wants some paper to write on, so I'm about to give her some
Okay.
paper. This is Janae. Janae, say hi to
Hi,
everybody.
Janae.
Okay, go ahead on. Bye bye. Sorry about that.
No problem.
I've been on grandma duty today.
Oh, nice, nice. And
I
women
have.
need to talk to each other. I mean, traditionally, my grandmother, she wouldn't talk about that kind of stuff. Maybe your mother might,
Right.
but I think now we're moving into where we have our sister circles and we have our friends and, cousins or what have you around our same age that we need to talk
Yeah.
to each other because someone might tell you about something that you never heard of or that their doctor didn't mention to your doctor didn't mention to you, but their doctor did. So we need to share so that
Absolutely.
it's not a secret. We don't need to suffer in silence.
We don't need to suffer in silence. You're right, because that Vioza, I had never heard of it before.
Yeah, yeah.
And it's certainly something that I would consider, because I have been having hot flashes since around 2009, and we're in
Mhm.
2020 now. So
Right,
I'm about,
right.
I'm about tired. I'm about tired.
Exactly.
I've been asking my doctor about that.
Yes,
Next
absolutely.
time I go to see her
Yeah,
about this Viola and if it might be a good option for me. Yeah,
right.
Nicole said we need to ask questions and talk about these options slash issues. You were so right.
Yes.
And Elder Dixon, listen, let me just thank you, sister, because you shouting out everybody on there. I appreciate you, sister. Listen, you have to be on here every week and just shout out everybody, okay? I want to thank you so much. And yeah, she's right, sister. the sister conversations. And she was also asking if you know what might be some side effects of the Veoza. Is it the Veoza that you are talking about?
Yes, she's saying yes. So
Mhm.
the all of the side effects on the studies were less than 5%, so that's a good number. But
That's a great number.
particularly, what the first side effect was hot flashes. So I thought that was funny because
Right.
what you're treating, how is that a side effect? But that's the first side effect it listed. Uh,
Right.
GI upset, stomach upset, uh, diarrhea, and a little back pain and insomnia. It was very few side effects, and they, like I
Okay.
said, they were all like 3 to 4% out of the study that they did. So I
Yeah.
thought
Yeah.
that was good numbers. That was good
That's a
numbers.
very good number. Yeah.
One of my colleagues, she said she has 5 patients on it now, and they all have not had any complaints. They're like,
Yeah.
it has changed their life.
Hmm. And the side effects that you mentioned, none of them sound particularly life threatening.
Right, right. You just can't, if you have any type of liver disease or chronic kidney,
Hmm.
you cannot
You
take
can't
it.
take it.
Right.
Yeah.
But other
Yeah.
than that, those side effects, like you said, it's not, a little abdominal upset. I mean, if it's severe, then of course you're not going to continue it. But
Yeah. Yeah.
I think the number one you would stop is the hot flashes because
The hot flashes,
you're
right?
taking it for hot flashes. So
Right.
what
Well,
is that about?
abdominal upset is one of the side effects of almost anything you take by mouth.
Right. That's true. That's true.
Almost anything. So, hi, Gail. Gail said she's loving this. So,
Gail
thank you.
is my first cousin.
Oh, hey, all right. Thank you, Gail, first cousin. Yes, and I want you all to show some appreciation for Dr. Page being here. And again, any questions, put them up there. Any questions, any comments, we welcome them because we want this to be as interactive as possible. And again, I would appreciate if you would subscribe to the YouTube channel, Marriage Beyond the Breach. You see it there on the bottom, Marriage Beyond the Breach. Okay, hold on. Angel just wrote something. She said there's been an increase in the diagnosis of PCOS among our younger women and girls. Yeah, that's true, which
Mhm.
seems to be impacting their ability to get pregnant and carry full term. That's very good. So, Dr. Page, can you talk about that for a little bit?
Um, Increase in diagnosis, I wouldn't say like there's an uptake of all of a sudden women having PCOS. I think we're again, advocacy, especially in women of color, has now
Mm,
made doctors say,
mm,
oh, because you haven't got your period and you have all the symptoms, dark neck, a little hirsute. Oh, is everybody in your family hairy? No, everybody in my family is hairy. But, they tout these things and again, ignore. So I think now it's more of the advocacy that has increased the diagnosis of PCOS. But
mm-hmm.
what's
And
the
for
other
those
part
who
of
may
her
not
question?
know, tell them what PCOS stands for.
So polycystic ovarian syndrome is what it
Mm-hmm,
stands for. And
mm-hmm,
women can suffer again a lot of pain, irregular periods. Diabetes is a big disease that goes along with it, being hirsute, which
mm-hmm,
means very hairy as well.
mm-hmm.
Um, and then the inability to get pregnant because you don't cycle normally. So you're
Right,
not
right,
ovulating as a normal woman would, so to speak. And I don't even like to use that word normal because you're not
right.
abnormal if you have PCOS. But for all intents purposes, your
Mm-hmm,
cycle isn't like a normal, 28 to 35-day cycle per se. And
mm,
so the key is to get you to cycle because you definitely have follicles and ovaries. There's
right.
nothing wrong with them per se. In fact, you may have more, hence the word poly. But to get you to cycle so that you can ovulate, and now, with IVF and all of these modalities, women don't have as much of an issue, but these things unfortunately cost money. So again,
Right.
Black and brown people may not have $50,000 to drop on an IVF cycle, and a lot of
Mhm.
insurances, if you don't have one of those jobs that is going to cover that at least one cycle or so, the medications themselves, very expensive. Um,
Very expensive.
so yeah, it does impact their ability to get pregnant. I
Mhm.
would not say women that I've had get pregnant. I wouldn't say, and I would have to look up that study because I don't know at the top of my head if it prevents them from carrying full term. But she may be right. But I can't say in my experience that I had a significant amount of preterm deliveries from women once they got pregnant with
Yeah,
PCOS.
yeah. But it does interfere with their ability to
Absolutely,
become pregnant.
absolutely, yes.
Yeah,
And
yeah.
a lot
Because
of
I
them, you
feel
just give pills called Clomid, which is an old
mm,
medication
that is
to
yeah.
get them
Mhm.
to ovulate, and that works. You might throw some metformin in there because they really figure although they're not technically diabetic per se, the
Mhm. Mhm.
metformin in conjunction with the Clomid, the studies are better in terms of increasing that rate of fertility.
Ah,
Um,
okay,
so
okay.
yeah.
Do they ever put them on birth control pills?
You can put them on birth control pills to try to cycle them as well. And the thing with
Yeah.
birth control pills, when you come off, you kind of super ovulate in the immediate period that you come off. So that
Ah,
may work as well. Um, Angels asking, are there any natural or holistic options?
options. Yeah, for
Not that
PCOS.
I'm aware of, but I'm sure there are some out there.
Mm, okay. All right. This is good. This is real good. So, what are some advancements in medicine that are currently impacting women's reproductive health?
Mhm.
And what future innovations do you find promising?
So the advancements that they're trying to take back with the IVF and all of that,
Mhm.
making women, because they're making all of these embryos, and now if they don't use them all, is that considered
Right.
abortion? So all that
Mhm.
craziness that's going on now about
Mhm.
women's tying it into abortion and all of that stuff. But
Mhm. Mhm.
IVF has really, from the time that I started
Mhm.
out to now, it's like anybody can basically get pregnant. It may take a few cycles, it takes a lot of money, but it's not all dark and bleak, like it used to be, so to speak.
Right.
um for that, um the Da Vinci robotic device that we do has just
Yeah.
revolutionized surgery.
Yes.
Back
It
in the
has.
day, you had a hysterectomy and you may
Mhm.
yourself may have stayed in the hospital 3 days, 4 days, what have you.
Mhm.
You go home the same day now after
Same
your
thing.
hysterectomy with that robotic Da Vinci. So
Mhm.
that has
Mhm.
just, all of the robotic surgery and using AI, so to speak, to help you with, has just really revolutionized surgery,
Mhm.
laparoscopic surgery. People are going home the same day for stuff that was major. They stayed in the
Yeah.
hospital for days for now. Um, so
Mhm.
that is, new. The pill I just spoke about for menopause, that's huge.
Mhm.
Especially
Mhm.
being non-hormonal, to really address hot flashes. That is good as well.
Yeah, that robotic surgery is amazing. Even for men, for their terps and
Yes,
things like that, using
exactly.
the robot change just totally changed the game.
Yes, yes.
Now there was a big learning curve in the beginning, but
Hmm.
now that it's being utilized more, the procedures are taking less time. I
Right,
remember when the surgeons first started using the robot, it would take them 2 or 3 times longer than surgery done the traditional way. But
right,
now that they're doing it more often, it takes about just the same amount of time as
right.
doing surgery the so-called traditional way. Yeah.
Exactly. Yeah. But before hospitals, that machine is a lot of money. So every hospital wasn't couldn't even afford
Yeah.
to buy it necessarily. And then you only want top doctors or surgeons. At one point, everybody was fighting to use it, but now
Right.
residents are training on it, and
Mm-hmm.
it's just part of the core now. So
Yeah.
yeah.
Okay. So I'm wondering, how does the healthcare system, if they do,
So,
support women's reproductive health issues, and what improvements would you like to see?
huh. How are they supporting now? I think all of the press we have, so to speak, about maternal morbidity and mortality. Um,
Mm,
but it shouldn't take all these women dying. I mean, women have been dying for years, but now in the news we see women dying during childbirth, trying to advocate for themselves, um,
mm-hmm,
and still no one listened to them or heard them,
mm,
and now they left these newborn babies behind. But now we do have within the hospital systems, and I'm not convinced that it's working, because you can make somebody do a course, you still can't change their heart and how they practice. So now
right.
there are all these
Whoa, 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 whoa. Say that again. Say that again. Say that again.
you have all these courses that they have mandated on disparity and inequality, but you cannot change somebody's heart or how
Mm-hmm,
they practice or what they
mm-hmm,
think about you as a person of color. So they
mm-hmm,
go through the motions completing the courses, but has it really changed anything? And I think
mm.
eventually through time, because you have to hit people in their pocket. And
Yes,
it's almost like, the NBA, when they act up, they get fined. You need
right.
to start, when doctors unfortunately are not doing right by patients, you
Mm-hmm,
have to reprimand them somewhere, threaten their license or what have you. And as
mm,
more patients speak up, and people really listen, then they'll, will address and do the right thing and respect a woman when she says, something doesn't feel right. Or like even Serena, as popular as she is, when she had her baby, she couldn't breathe. Her husband had to keep advocating for her, and then she ended up having a DVT. I mean,
mm.
it's crazy. No one is listening to us. So
Yeah.
I do see movement on paper with
Mm,
trying to address that. And here in New York, Charles Schumer is really trying to do a lot with that. He has the omnibus project, which he's taking individual hospitals and really trying to revamp their labor floor. So things
mm-hmm.
are happening, probably not fast enough,
Yeah.
but definitely that needs to be addressed. What was the other part of your question?
What changes would you like to see?
So more changes on that. Definitely on,
Mhm.
I would love for a woman of color to go into the hospital and get the same level of care and respect that a
Mm,
white counterpart does in having a baby, and not being rushed to have a cesarean section, especially at 21 years old, when you probably want to have 2 or 3 more kids. And now we've committed your
say it.
uterus to all these scars. Um,
Mm,
but respect and take time, and don't rush because you got a golf game to cut this woman. And that's just
that's right.
reality. And if
That
the
is.
more we admit that and say that that
Mm,
is what is going on sometimes,
mm-hmm.
uh, uh, that would help. On the same token, because one of my best friends and I, we talk about this. Patients have their part too, and
Right.
you have to own up. I say we have one of the most important things in our toolkit, and they don't use it. They can
Mm,
Google everything else, but what about your whole pregnancy and the stages and advocating for yourself, but also doing what you need to do, you know? So that
right.
goes hand in hand as well. So that would be just a beautiful thing if patients started educating themselves more, and
Mm-hmm.
doctors started listening more, and it be a symbiotic relationship, that the
Mm-hmm.
ultimate goal is to send this woman out here with a healthy baby and for her to be healthy. That is the goal at the end.
Let's
That's what we want to
go.
do. Yeah.
Yes. Yeah, you are so right about that C-section. I remember when I was in labor with Sidel, our first child,
Mm-hmm.
and I was in labor for a long time. But I think probably the last 12 to 14 hours or so, I was in the hospital.
Mm-hmm.
And I remember saying to my husband, I said, Frank, I said, after a while, he's going to come in here and probably ask you out into the hallway and talk to you about me having a C-section because I've been in labor for a long time. This was Monday night, and I had been in labor since Sunday night, and I didn't have her until Tuesday morning.
Mm-hmm.
Okay. So this was Monday night. And I told him, I said, I don't care what he says, as long as she is not in distress,
Exactly.
I don't care how much it hurts. I am not having a C-section. 3, 4 hours later, here he comes. Mr. Chase, can I speak to you for a minute? And Frank and I looked at each other because I knew what was going to happen because I'd seen it. I'd seen it happen so many times. And
Right.
he took me out in the hall, and Frank came back, and Frank said, "Wow, Val." Sure enough, he said, your wife has been in labor for so long. Maybe we should just consider doing a cesarean section. And Frank said he told him, said, no, my wife said, as long as our baby is not in distress, she's going to just tough it out. We're not doing a C-section as long as the baby is okay. And I
Right.
had said that. I had made that vow to myself before God. I am not doing that section because I knew this was our first child.
Right.
And not always, but at least back then, because Sidel was born in 1982.
Mm-hmm.
Back then, once you had a section, every child after that had to be born by section back then. I think they're trying to get away from that now. And you can
Right. We're
speak
doing
about it.
VBACs, but even that's, that's still risk because you have a scar in your uterus. So your risk of
Mhm.
rupturing and all. But I mean, I think just a beautiful labor floor is allowing a doula, allowing a midwife, and the OB is there, particularly for high risk and stuff, as backup. But it shouldn't be that you're the enemy when you come with a doula. You're the enemy because,
Right.
there are lots of hospital systems. I was taught by midwives during residency. So it's no reason we can't work together,
Right. Right. And just like you, Elder Gail, I had all 3 of our children vaginal deliveries, but that would not have been so had I allowed the OB-GYN back then to just go ahead and do this and do the sections. But I refused. He was mad. He wasn't too happy with me that day, but I didn't care. I didn't
Right.
care. We have got to take that stand. This is our bodies and our babies.
Right.
Our bodies and our babies. Oh, Elder Gail said, talk about epidural.
Epidurals in a what I'm trying to say, an epidural in a qualified anesthesiologist's hands is no problem. All the studies say it does not slow down your labor. I mean, you shouldn't get it at 1 centimeter, but epidurals are very safe if like anything else. I mean, you can go in for something simple and something go awry if the person doesn't know what they're doing, colonoscopies, so yes, epidurals, if done by a qualified, certified, board certified anesthesiologist who works on the labor floor, for the most part, that's their job, not a problem.
Yes, yeah. Someone who does this on a regular basis.
Exactly.
Not the anesthesiologist who happens to be on duty that day, but he or she does not do many epidurals. Exactly. You don't want that person giving you one.
Right. It's like I used to joke in the labor floor, and some of my patients, I don't want the nurse starting my IV or drawing my blood. I want you to do it. I said, no, you want them to do it. They do this every day. I don't do this every day anymore. So yeah, you want them to do it.
Want us to do it. Absolutely. Yeah. Absolutely. So at what point, because I never had epidural, so I'm not sure at what point a woman would receive one. Do they get it before transition or during transition or when?
Usually active labor. That's when you get it, when you're
At,
in
at
active
any
labor.
point, at any point in active labor, you can have it.
Right. I mean, some
Oh.
women is 9 centimeters. We give it to them. It
Mm.
shouldn't be again that, because who am I to tell you tolerate your pain more just
Right.
because you're 9 centimeters?
Right.
Maybe you just can't
Mhm.
take it anymore and you're out of your brain, so
Yeah,
we give it
that's
to
good.
them. Yeah.
Yeah, I'm with you. Who's this? Eileen? I hope I pronounced your name correctly.
She
No,
refused
Serlene.
that.
Serlene, I hope I pronounced your name correctly. You refused an epidural? I did too, sis. I refused epidural, but listen, I don't know. That was 1982, 1983, and 1985. If I was having a baby now in 2024, I might do things a little differently. But back then, I was hardcore back then. I ain't as
Right.
hardcore now as I used to be. But so I can't believe we did make it. It's 11 minutes after 8, and we did make it through the questions. But I want to
Well,
ask you, Dr.
Elder
Paige.
Dale has one more question, which I think
Okay,
I
what
can
else?
address
Right.
because it's important in Black women. I think she says one more concern. I think she meant to type fibroids in Black women.
Oh, yes. Go ahead. Talk about that.
So we know fibroids for the most part is an extra growth within your uterus. It could be outside your uterus. Think of your uterus as 2 slices of bread. So it can be outside the top of the bread. It could be between the bread, or it can be on the bottom layer of the lower half of the bread. So those are the 3 types of fibroids that we have. The ones that are in below the bottom layer of the bread, those are the ones that cause the most complications with bleeding and trying. Fibroids technically should never prevent you from getting pregnant, but once pregnant, the ones inside can be the ones that's causing a problem. The one in between the sandwich are the ones that can cause the most difficulty during surgery to remove, and the ones outside, piece of cake, because a lot of times they're pedunculated, meaning they have a stalk that you can just pretty much tie off the stalk and take them out. 99.9% of the time they are not cancerous. That's why we don't force you to remove them because we think they are cancer. They can grow as big as a 9-month pregnancy. They can be painful depending what they're pressing on. A lot of common symptoms are frequent urination because it's pressing on your bladder. It's like going from hell to heaven.
Yeah.
Epidural. Oh my gosh, that's cute. From hell to heaven.
From hell
Okay.
to heaven. That first 2 were
But
natural, but had an epidural with the third and never look back. I hear you, Nicole. I hear you.
yeah, I had
So,
an epidural too, and I wouldn't say from hell to heaven, but I remember my husband saying, "You are embarrassing me," because that's how crazy I was acting with the pain, because I had pitocin on top of it, and that just takes it to a
oh,
whole
that
new
makes it
level.
worse.
Yes.
Yes.
So,
Yeah. I had Pitocin with Hammy with my middle child.
uh-huh.
Yes. Yeah. That intensifies your
Right.
labor exponentially.
Right. So I can relate. But yeah, fibroids, traditionally we see them more in women of color. Doctors traditionally used to just want to whack out your whole uterus. You got to have a hysterectomy. We do myomectomies, which is just removing of the fibroids itself. But we always consent you for a hysterectomy because you never know, am I going to let you bleed to death or take your uterus? So I'm going to tell you ahead of time, I'm not going to let you bleed to death trying to save your uterus from removing this fibroid.
Right.
This, we say the surgery was a success, but the patient died. No.
Right. Absolutely.
Yeah, that's with the surgery. But people get multiple myomectomies, which is removing the fibroids. But again, each time that's cutting into your uterus. Now, again, with Da Vinci and all of that, things are a lot better. You're not opened up, because every time you're open, then scar tissue and all of that when you close But they can make some women's life very miserable with the bleeding,
Oh yeah.
heavy menses, sometimes bleeding all month. Um, just really bad. There is birth control to try to control the bleeding. There
Mm-hmm.
is Lupron injections, which will put you into a chemical menopause, but you can't take that
Mm-hmm.
more than
Mm-hmm.
6 months. Depo-Provera, which is a birth control shot, but the side effect of that is amenorrhea, no bleeding. Sometimes
Mm.
that works for women with fibroids, but obviously, if you're on a birth control, you can't get pregnant if you're trying to get pregnant.
Right.
And what else about fibroids? I guess that's kind of it in a
Yeah.
niche.
There was one other question Elder Gail has. She asked, "Do fibroids shrink with menopause?"
Well, estrogen is what feeds them. And yes, they can get smaller in size, but if you starting out with a 9-month size, it'll go down, but it's not like it's gonna disappear. So
Right. Right.
it's
It might go from a 9 month pregnancy looking to about an 8 month.
exactly. So you still need to take care of that.
You couldn't take care of. Actually, fibroids was the reason I had a hysterectomy. My doctor actually didn't want to do it,
Mm-hmm.
but I was in her office crying because the vaginal bleeding that I had, it was awful. It was at the point where I was wearing a diaper
Mm-hmm.
because the bleeding was just, I mean, it was so incredibly heavy. No matter what I did, I would end up soiling everything I wore.
Right.
I would have tampons inside plus a sanitary napkin and a diaper.
Diaper. Yeah.
That's how heavy the bleeding was. And when she kept telling me, "Oh, Mrs. Chase, just wait." And I said, "No, I'm not." I started crying. I said, "I'm not getting up from this chair until you agree to my hysterectomy." I couldn't live like that anymore. It
Right.
it was it was taking over my whole life for that
Which
amount
it
of time.
which it does. Two other things I forgot. Uterine artery embolization is
Mm,
another modality to treat them, and that's cutting off the blood supply to your uterus.
mm-hmm,
Again,
mm-hmm,
not recommended if you're trying to get pregnant. And then there's endometrial ablation, which is basically frying the
mm,
whole lining of your uterus. These are, if you're a woman 30s with still, yeah, a good ovarian reserve, they're only temporary. They're not
right.
permanent fixes. So, but
Ah,
these are
okay.
things, especially for perimenopausal
Mm-hmm,
women, to buy them time. I would recommend these things so that they don't have to have surgery, because surgery is still
okay.
surgery. You know,
Surgery to surgery. Right.
yeah. Dryness
Um.
at 70 with intercourse. So,
Yeah.
Gail, I guess you missed all of that. We talked about hormone replacement therapy in terms of hormonal versus non-hormonal. The
Mm-hmm,
non-hormonal ones, particularly for hot flashes, but for dryness, there are all types of creams, anything
right.
from prescription like estrogen cream for dryness versus over-the-counter lubricants for
Mm-hmm,
dryness. But
mm-hmm,
it's all because of the vaginal mucosa has become atrophied because of the loss of estrogen,
mm-hmm.
that you have that dryness. So lots of different lubricants, things as strong as prescription, things as simple as over the counter.
Yeah, I would start with over the counter, and because whatever you get prescription may be something a little bit stronger, but usually over the counter will work. You and
Right.
your partner have a conversation about it, and you can make it part of foreplay actually,
Yeah.
uh, using the lubricant, right, Dr.
Right.
Page?
Yes. Yes.
You don't have to go hide in the bathroom and,
Oh
and,
no.
and put
No.
your lubricant on.
No.
You can make it part of foreplay where your partner actually applies the lubricant on you
Correct. Correct.
or on his penis, whichever.
Yeah.
Whichever. So, what about endometriosis?
Uh Very painful as well. That
Mm-hmm,
is the lining of the uterus growing anywhere outside the uterus. And it can be
mm-hmm,
anywhere. Common areas, pelvis, most commonly ovaries, and pelvic side walls. But I've seen
mm-hmm,
it in the umbilicus, the belly button.
mm,
It can travel. Very painful. Traditionally, it was only diagnosed with laparoscopy, actually laying your eyes and seeing it. And when you
mm-hmm,
see it, You cauterize any area that may look, they typically look like somebody put a bunch of cigarette burns throughout your pelvis. Could be anywhere from black to white. But some women, they don't have it visually, but they still have the pain as bad. So it's very hard to really treat and manage that. A lot of pain medications, sometimes birth control, because you're suppressing the ovaries from putting anything, out. So you're suppressing that ovulation, which is why they get that cyclic pain. Like I said, you might, if you see it, burn it. And then some women, they take their ovaries out. They just can't take it anymore.
Can't take it.
Yeah.
Okay. Oh, Dr. Paige, this has been phenomenal. But I wanted one last thing. How can women be their own best healthcare advocate in conversations with their healthcare professionals?
Well, I think you answered that earlier when we were talking about find another doctor if you're not happy. Tell your doctor, slow down. I don't understand you. If they have to repeat it 3 or 4 times, then that's what they have to do. If they get upset, then that's time to get another doctor.
Right.
Bring somebody with you. A lot of times they may understand a little bit better. Do FaceTime. Like, my dad went to his cardiologist the other day. So he calls me. So I'm right there asking the questions, talking to the doctor. And another thing, for maybe not so much for yourself, but as we get older, and those of us who still have elderly parents who may be in long-term care facilities or nursing homes or what have you, there's the ombudsman, who is a public advocate, usually affiliated with the institution, or you can call and see who would cover that facility, and they can help navigate the healthcare system for you as well.
Yeah.
So you don't have to be alone. And the power of the pen. They don't like letters. See, we as people of color, we want to curse you out, tell you off right then and there, whatever. And that gets released some stress, and it may, help right then and there. But when you put pen to paper, things change.
Right.
So a rude doctor, write a letter. Something you have to answer. He or she is going to have to answer to somebody. She's like, wait a minute, can you explain what layman terms? What does she mean explain what?
Well, if the doctor's talking over your head and talking in medical terms that you don't understand.
Right. Oh, right. She's saying
Not
the same.
you,
Exactly.
in general, if you're at your doctor's office,
right,
and that's happening, absolutely.
Right.
Yeah.
Right.
Yeah, just like you did for your dad. I do that with my sister. When she goes for to see some of her physicians, she will have me on the phone. We may not do FaceTime, but sometimes she has me on for the whole visit, and I'm interjecting and I'm asking questions, and what about this, and what about that, and what about the other thing. And if you have a husband or a boyfriend or a significant other, a male, please go with that, because men are notorious. They are poor historians. They don't always give all the information of what's wrong with them. Okay. And they won't always ask the right questions.
Right.
Okay. I always have to go with my husband. He was having surgery the other day, and when the anesthesia provider came in, asked him about any cardiac issues, my husband says no. He's got a history of AFib, and once went into SVT in response to anesthesia. How you gonna say that?
Wow.
Yes. So yes, go with someone, or have someone go with you. It helps if they have some sort of medical background, but they don't have to.
Exactly.
It's just someone who knows how to ask questions and seek information. That's the most important thing. and
Yeah,
just not take what this person says just at face value. And it's not that you don't have confidence in your healthcare provider, but you want to be sure that your questions are answered, that you ask the right questions, and that you get the answers that you were seeking. And if not, like we're saying, go somewhere else. If he or she cops an attitude, that's not the right doctor for you.
absolutely, absolutely. And another thing, um, I remember I had a gastroenterologist doctor, and she would talk to me the whole time with her back to me. And
Oh.
I was like, okay, I'm gonna give her, like, she did it the first time, I give her one more time. And she
Hmm.
did it the second time. And then I just told her, I said, I will no
That was
longer
it.
be coming back to see you. And I said, and just
Mm.
FYI, I'm a physician as well. Because I don't
Yeah.
tell doctors I'm a
Wait,
physician.
I don't tell I'm a nurse
I
either.
want to
I
see
never
how they're
say
gonna
that. Yep.
act. Um, and I
Hmm.
said in your heart. And but then she wanted, oh no, no, you don't get to be my friend now or try to treat
Right.
me in a certain way. So yeah,
Yeah.
look for those things as well. If someone's talking, their back is to you all the time, they're like uninterested, that's not the doctor for you.
Right.
So
And another thing, now that they have computers in the examination room, they're looking down all the time
right,
as opposed to making eye contact.
right,
Sometimes if they ask me a question, I won't even answer until they look up.
right, right. Yeah,
Something that Nicole said, that's really good, Nick, to write down your questions so you don't forget or get stage fright when you're talking to your healthcare provider. That's good.
right,
Before you go, try to write your questions down because it's hard, especially if it's a serious health issue. You may not remember while you are there to
right,
all of the questions that you may want to ask. And Angel is saying, keep family members updated about your health, your diagnoses, medical treatments, etc. That's really good. You do need to keep your family members, your safe, trustworthy family members, because they need to be safe.
right, right. And everyone
Yes,
should have a healthcare proxy.
healthcare proxy, absolutely. Healthcare proxy, because you don't think that because you're 35 or 40 years old that you don't need one. You do need one.
Absolutely.
You do
Yep.
absolutely need one. So wow, I can't believe it's 8:28. Oh my gosh.
We've done
Dr.
our
Payne,
hour.
this was phenomenal. Those of you who are watching right now, please show some appreciation for Dr. Paige Long Sharps. This was great. This was great. This was great. And those of you who are on, again, excuse me, if you haven't already done so, I would appreciate you going to our YouTube channel, Marriage Beyond the Breach, and subscribe and click on the notification bell so that you'll be notified every time we are having another broadcast. We won't be here for the next 2 weeks because next Sunday's Palm Sunday, and then after that is Easter Sunday. But then we're going to be back. I have to look in the calendar because I don't remember what the next. Come on, calendar, open up. I may have to go on my phone because my computer is acting crazy. So that will be so the 24th we won't be here. The 31st we won't be here, but on the 7th we're going to be back and we're going to be talking about when your significant other has been diagnosed with borderline personality disorder. We've been covering some mental health care issues and how to navigate them when you are in a committed relationship with someone who has that. So the next one will be borderline personality disorder, and that is going to be on April 7th. So again, Dr. Page, thank you so
Thank
much.
you.
Those of you who are
Thank
watching,
you.
thank you, thank you, thank you. I pray you have a blessed Easter and a blessed Palm Sunday and actually a whole blessed life. And advocate for yourself and
Yes.
advocate for your family because we only got this one life and all this one body. We'll get a glorified body when we get to heaven, but we ain't there yet. So we need to
Yes.
take this one we got. Right, Dr. Page?
Yes, absolutely.
All right. I love you guys. Thank you so much. And
Bye.
I will see you all next time, April 7th. Be here.